Hello everyone, welcome to Path Excellence. Today in this endometrial pathology video series episode 13, we are going to discuss diagnostic criteria for well-differentiated endometrial carcinoma on biopsy. In previous episode, we have discussed how it is easy to diagnose this carcinoma with the help of myometrial invasion in hysterectomy specimen. But as we know, endometrial biopsy, when we get, it is very small in amount and it is difficult to say invasion in the biopsy specimen. So, let's see how we can judge endometrial biopsy for endometrioid carcinoma, which is well differentiated. So, why this criteria matters? Diagnosis directly influence clinical management and treatment planning. So, many challenges to differentiate atypical hyperplasia or EIN versus well-differentiated carcinoma. So, sometimes this hyperplasia without atypia rarely mimics carcinoma because no nuclear atypia, but atypical hyperplasia is in the differential diagnosis. So, we must avoid interpreting benign mimics like tissue artifacts, pregnancy-related changes, epithelial cytoplasmic alteration. Now, the diagnostic challenge is that low-grade endometrial carcinoma can be difficult at times because these tumors do not always show clear-cut destructive stromal invasion. So, in biopsy, destructive stromal or myometrial invasion is rarely seen, and hence diagnosis depends on recognizing patterns indicating stromal invasion because invasion is a logic criterion for separating frank carcinoma from atypical hyperplasia or other lesions that mimic carcinoma. So there are three morphologic patterns defined to establish carcinoma. So, presence of anyone means carcinoma is there. So, what are these core criteria for stromal invasion? It is confluent glandular pattern. Second is desmoplastic or altered fibroblastic stromal response. Extensive papillary pattern. And this objectively separates carcinoma from EIN or atypical hyperplasia. Now, quantitative guideline indicates that the diagnostic area should involve more than 50% of a scanner view or 4x field, which is equal to 2 mm of area. It helps avoid pitfalls like tangential cutting or minor artifacts. And exception is that if invasion pattern is clearly present, diagnosis of carcinoma should be made even if the area is very small. So let's see all the criteria one by one. So first one is confluent glandular pattern. Here, by definition, glands merge without intervening stroma. There is Cribriform arrangement with true luminal bridging, gland-in-gland or complex labyrinth architecture, and exists normal gland size and shape, and whenever there is squamous modules which can bridge lumen, it should not be included in criteria of stromal invasion. So here this is the section showing endometrioid carcinoma well differentiated. This is confluent glandular pattern. Here we can see there is Cribriform arrangement and there is no stroma at all in between these glands. So this is a confluent gland pattern, in which means merging glands with each other. And this is endometrioid carcinoma FIGO grade 1. This grade system we will discuss in later part. Again, this section we can easily identify lumen of the gland, but here also there is no stroma in between glands. and they are fused, indicating stromal breach. So this is confluent glands with fused or here some cribriform arrangement. Again in this section, this is confluent gland pattern which is seen as a large irregular glands that interconnect continuously throughout the field, and there is no stroma here. So this is again endometrioid carcinoma confluent gland pattern. Now second criteria, which is desmoplastic stromal response. So atypical glands fit in reactive fibroblastic stroma, not endometrial stroma. So how to identify desmoplastic stroma or how to differentiate it from normal endometrial stroma? So here this fibrous stroma having spindle fibroblast, elongated nuclei and collagen. So it gives eosinophilic background, and there is architectural distortion and gland irregularity. So mimics to avoid are polyp, mark inflammation, atypical polypoid adenomyoma, and lower uterine segment histology. So these additional criteria we have to use to confirm malignancy with the presence of glandular irregularity and back-to-back arrangement. So here this is desmoplastic stroma. So desmoplastic stroma means fibroblastic mesenchymal tissue which encompasses the neoplastic gland. So here we have to see that these are the neoplastic glands, and in between this is desmoplastic stroma. So this is a criteria to identify stromal invasion in biopsy specimen. Third is extensive papillary pattern. So diffuse branching papillary fronts with thin fibrovascular cores and much more complex than small tuft in atypical hyperplasia or focal syncytial change in benign polyps. So here papillary patterns are also present in these two lesions like atypical hyperplasia and benign polyp, but they are having small tuft or sometimes without fibrovascular cores. Here there is extensive papillary pattern, so branching papillary front and with two papillary architecture means thin fibrovascular core is present, and serous carcinoma is also having this papillary pattern, but here there is high grade nuclei which is having aggressive papillary tufting. So we have to differentiate well differentiated endometrioid carcinoma with serous carcinoma with the help of high grade nuclei, because well differentiated endometrioid carcinoma will have a minimal nuclear atypia. So this is the important point to identify serous carcinoma. So here we can see this is extensive papillary pattern with fibrovascular core, and this is having low grade nuclear atypia, means this is low grade carcinoma with viloglandular, means finger like projections and multiple delicate true papilla with fibrovascular core. So this is the third pattern for well differentiated endometrioid carcinoma. Some rare additional pattern can be seen like sheets or nest of bland squamous cells as an invasion marker, but they are rarely helpful alone, and usually they coexist with confluent glands or desmoplasia. So these are the differentiating points to differentiate atypical hyperplasia or EIN with well differentiated endometrioid carcinoma. So these are the features like architecture in which there is stroma in between the glands. Here there is confluent or merging glands or cribriform pattern. Stromal response none, and here there is desmoplastic stroma. Papillary pattern focal or no cores. while here extensive branching papillae. Diagnostic criterion like cytological atypia plus gland crowding. Here any stromal invasion feature must be there. Quantitation, EIN having less than 55% of glands are involved. Here we have to see low power field, where half of the low power field must be showing this invasion or carcinomatous feature, means there is more than 2 mm of area, and myometrial invasion is not seen but possible in hysterectomy specimen. So here, why this criteria work? So there are the evidence from hysterectomy correlation studies. It says that stromal invasion absent in biopsy, but in hysterectomy there is 60% had myometrial invasion, and stromal invasion present in biopsy, and at that time in hysterectomy specimen 62.5% had myometrial invasion. So equal to 50% cases show residual carcinoma, more than 1/3 show upgrade to grade 2 or 3 carcinoma, 25% have deep myometrial invasion. So that's why accurate biopsy diagnosis is crucial for management. And the key take-home message is that any one of the following, like confluent gland or desmoplastic stromal reaction and extensive papillary pattern is present, that means carcinoma is there. Apply quantitative rule, means more than 50% of thorax filled when possible. Always correlate with cytologic atypia and clinical context. Diagnose well-differentiated endometrioid carcinoma when architectural complexity, stromal invasion pattern is present, and even without myometrial invasion in biopsy, call it carcinoma confidently. Now let's see histologic grading for endometrial carcinoma. Why grade is important? Because grading predicts tumor behavior and prognosis, and it also guides management decision, especially early stage disease. So there are two types of grading according to FIGO. One is architectural grading, which applies to endometrioid type only. So it is not applying to serous carcinoma or clear cell carcinoma. So these are the grade 1, 2, 3, where there is less than 5% solid non-squamous area, which shows predominantly glandular pattern, and it is having best prognosis. 6 to 50% having solid areas with mixed glands and solid areas, intermediate prognosis. Grade 3, where 50% or more than 50% solid area, predominantly solid sheets, having worse prognosis. So squamous area are excluded when estimating solid components. Now nuclear grading in endometrial carcinoma. So architectural grading, which shows grade 1, 2 and 3, and this nuclear grading also integrated into FIGO. So this is nuclear grade is based on, one is nuclear size, pleomorphism, chromatin pattern, nucleoli, and mitosis, which increase with grade. So what are these nuclear grading criteria? So grade 1 is mild, in which we will see size, morphology, chromatin, nucleoli, and mitosis. So size we have to compare with normal lymphocytes. So size versus lymphocytes. Here grade 1 shows 2 to 3 times lymphocyte size, oval and uniform size, finely dispersed chromatin, indistinct nucleoli, and few mitosis. Grade 2 is moderate, where 3 to 6 times lymphocyte size, increased variation in size and shape, intermediate chromatin clumping, small but visible nucleoli, and moderate amount of mitosis. Grade 3, which is severe, which is more than 6 times lymphocyte size, marked pleomorphism, chromatin pores, mush or clump, and multiple macronucleoli and numerous atypical mitosis. So there is a rule, upgrade rule. If G1, G2 architecture is present and grade 3 nuclei is present, then increase FIGO grade by 1. And exception if architecture looks low grade, but nuclei are very atypical, then it is considered as a serous carcinoma, not well differentiated endometrial carcinoma. So here we can see nuclear grading, grade 1, 2 and 3. So here grade 1 shows small oval nuclei with smooth contour, finely granular chromatin. Compare with this grade 2, where we can say moderate amount of pleomorphism, small prominent nucleoli, and here oval to round shape. Grade 3, here there is round nuclei, marked pleomorphism, prominent macronucleoli, and coarse chromatin. So these are the how you can judge nuclear grade. This histologic grade may be modified by molecular subtypes. So here the subtypes include DNA polymerase epsilon ultra mutated, microsatellite instability hypermutated, copy number low, which is microsatellite stable, and copy number high, which is serous like. So here molecular profile having a very high mutation burden in pol ultra mutated, having excellent prognosis, and even if high grade morphology is there, there is good prognosis. In this MSI hypermutated, this is MMR deficient, good to intermediate behavior, and common in Lynch syndrome. Copy number low MSS, in which P10, ARID 1A, CTN and B1 having good behavior and mostly low grade endometrioid carcinoma. Serous like having TP53 mutation, aggressive in nature and usually serous grade 3. We have already discussed in our previous video, so you can go there and understand this molecular classification. Now limitations of FIGO grading. So there is inter-observer variability like architectural estimates, tumor heterogeneity, because whenever we get biopsy, some of the areas which are present in biopsy will have a different tumor grading or architectural grading in different areas. So it is depending upon the what type of tissue we are getting and low biopsy hysterectomy concordance. Now, proposed binary system is also there to improve reproducibility. Like low grade means FIGO grade 1 and 2, high grade which is FIGO grade 3, and alternative rule is high grade if more than 20% solid or associated with necrosis or infiltrative invasion. So whenever we see this criteria of necrosis solid pattern, we have to grade this according to the areas of a pattern. So low grade, high grade, these two binary system is proposed. So key points are: apply grading only to endometrioid carcinoma, incorporate nuclear atypia into final grade, molecular testing improves prognostic accuracy, and always correlate biopsy versus hysterectomy. So this is how you can judge carcinoma in a biopsy specimen when there is very well differentiated endometrioid carcinoma, which can be mimicked as atypical hyperplasia or EIN. So I hope this will be very useful when you see biopsy and when you have confusion to diagnose well differentiated endometrial carcinoma. So if you like this, please like, share and subscribe this channel for more such type of pathological videos. And in the next topic, we will discuss clinically important histologic subtypes of endometrial carcinoma in detail. So thank you and stay tuned.